All right. Good morning once again, everyone. Good morning. My name is Dr. Chihobo. Today I'll be taking you through ATLS, which is Advanced Trauma Life Support. So this is a course that you do for 3 days. We're just going to do the initial assessment and management. So ATLS started on the 17th of February 1976 when Dr. James Steiner was flying his plane with his family and they're coming from a wedding. So they crashed in Nebraska and his wife was quickly ejected off the plane and his 4 children, one of them suffered a fracture of the humerus and the others were in and out of consciousness. So after the crash, he went and looked for his wife. He found the wife was already dead. He managed his 4 children and then looked for help. So he flagged the car and then he was taken to a local hospital. So when he got to that hospital, they were initially not allowed to enter into the hospital because there was no doctor to admit. And then when the doctor finally came, there was no any method to the approach that they received. And when he saw one of the doctors carrying his child, he was putting the other hand under the knees and then the other hand on the shoulder with the neck dangling behind. He then decided that he had had enough and he called a helicopter to come and pick him up from that rural hospital to Lincoln in Nebraska, where they lived. So he then said, the quote that I wrote there on the board, he said, "When I can provide better care in the field with limited resources than my children and I received at the primary facility, there is something wrong with the system and the system had to be changed." So from there, he was contemplating on the idea of creating a course or bridge the gap that was there between people who saw major trauma on a regular basis and people who saw trauma maybe once or twice a year. So he then developed a course with Ron Craig and others. The first course was then developed in 1978, and that provided a framework for managing of major trauma. And in 1980, it was then adopted by the American College of Surgeons Committee on Trauma. And then from there, it was introduced internationally. And here in Zimbabwe, it's trained at Mater Dei Hospital in Lawa. So what the course aims to do is to make sure that when you see a patient, you assess the patient rapidly and accurately. You resuscitate and stabilize the patient according to to priority. So there's an order which you use to resuscitate the patients, and you determine whether the patient's needs exceed your resources or the capability of the providers that are there. And if the needs of the patient exceed the resources or the capability of your facility, you then arrange appropriate inter-hospital or intra-hospital transfer, and you ensure that during the transfer or during the resuscitation, optimum care was provided and no deterioration noticed. So what you're seeing on there is what we call a trimodal distribution of deaths that occurred after trauma. So the first line that you see or I'll refer to it as a curve. The first curve that you see, the first red line, refers to this is the deaths that occur within seconds to minutes after trauma is occurred. And there is really much we can do to save these patients. So these are your patients who have severe apnea from either severe traumatic brain injury, high spinal cord injury, or from rupture of the heart, the aorta or large vessels. And then the second curve that you see there, the second red line, represents what we call the golden hour of trauma. So these are patients who have life-threatening conditions that can be managed. So these occur within the first hours after trauma. So these are a patient with your epidural hematoma, your subdural hematoma, your pneumothorax, your ruptured spleen, your lacerated livers. And then the third line that you're seeing on 1, 2, 3, 4, these are days that occur a day or a weeks after the initial insult. So these are the patients who then die out of sepsis. You've managed the patient, but the patient then die out of sepsis or from multi-organ system failure. So the initial assessment in its essence is a systematic approach that can be rapidly and accurately applied when you've seen a patient with trauma. So it has a lot of elements. So the elements include preparation, triage, primary survey, which are your ABCDs of trauma, with immediate resuscitation of patients, life-threatening injuries, and what we call adjuncts to primary survey and resuscitation. There's consideration for patient transfer, secondary survey, which is your head-to-toe evaluation and taking the patient's history, and then there are adjuncts to the secondary survey as well. And there's continued post-resuscitation monitoring and re-evaluation, then definitive care. So primary and secondary surveys are repeated frequently to identify any change in the patient's status and to see if there is any need of any additional intervention. So ATLS, the Advanced Trauma Life Support course, is taught in a linear progression, but in reality, the activities are done simultaneously, but still following the order of priority. So the first element of the initial assessment is preparation. So this is something that we lack in Zimbabwe, either in private or in public institutions. So, for example, you get a call from an ambulance technician and they tell you that they are bringing a patient. Most times the doctors just say, bring the patient, and then they don't even prepare to receive the patient. Or the people who are going to take the patient, they are not really fully equipped. So it has two phases, the preparation. There's what we call a pre-hospital phase and then a hospital phase. So during the pre-hospital phase, what you aim to do is to make sure that there's emphasis on the airway, there's control of external bleeding and management of shock, and there's immobilization of the patient and immediate transfer to an appropriate facility, or preferably a trauma center. And then the first responders should then obtain and report information needed for triage, including the time of the injury, the events related to the injury, and the patient's history. So when they come to the hospital, what they're supposed to do is to just hand over quickly. So it's a smooth and ensuring all the information is available. And when the receiving doctors should ensure that there's a resuscitation area that's already functioning and the equipment has been checked. You check if your laryngoscope, for example, if your laryngoscope is working, if you have the proper endotracheal tube size and it has been placed where it can be accessed easily. You warm your IV fluids, and then you make sure your monitoring devices are ready and working. And then there should be a protocol to summon any additional medical personnel, for example, the lab and the radiologist. And then make sure that there's already transfer agreements that have been set in place for further care and management. So triage is sorting out patients based on the resources required for the treatment and the resources that are actually available. So when you're triaging patients, the order still follows the ABCs. Your airway, breathing, circulation, I will elaborate more on that. And other factors that can affect triage include the treatment priority. Triage and treatment priority include severity of the injury, the ability to survive, and the resources available. So when there's a slide that's missing. All right, let me just look for it. Right, it's there. So when you're triaging a patient, there are two terms that we usually use, multiple casualties or mass casualties. So when we are talking of multiple casualties, these are in which the number of patients and the severity of the injuries do not exceed the capabilities of the facility to render care. So when you have certain situations where the number and their needs do not exceed the capability of your facility, you treat the life-threatening first and the multiple system injuries are treated first. But when you have mass casualties, for example, there's been 2 buses that have been involved in a road traffic accident along Samora. When you get there, you realize that the number of the patients that are there and the injuries that are there exceed the capability of the facility of the staff that are there. You then treat patients with the greatest chance of survival, requiring less time and supplies and equipment and personnel first. So with that in mind, there's just a simple scenario of triaging. So imagine there's been a multi-victim motor vehicle collision, and there's a situation in which multiple patients arrive in the emergency department from the major accident. Patient A is unconscious, has shallow respirations and absent radial pulse. Patient B is alert, reporting to severe pain from an open fracture, but has stable vitals. And patient C is alert, oriented, with superficial lacerations and no signs of respiratory distress. And these are the patients who usually make the most noise with the superficial lacerations. They might even threaten to sue you if you don't attend to them. And there are some things that we call distracting injuries. For example, this one is an open femur fracture. You see the leg is mangled, but then their vitals are very stable. People tend to then prioritize these ones with the obvious injuries. But in actual essence, this is your first patient that you should attend to. Is unconscious with shallow respirations, and the radial pulse is already absent. This points to life-threatening condition affecting the airway because they have shallow respirations and they are unconscious. Their breathing, their circulation, looks like everything is involved here. And this one, although it is life-threatening, their vitals are still stable. So you then attend to them later. And these ones, you then attend to them after you've attended to the first two. All right. So moving on to the primary survey with simultaneous resuscitation. So the primary survey is what encompasses the ABCDEs of trauma. And it aims to identify life-threatening conditions adhering to a certain sequence. So you get your patient, for example, the one who was in scenario A is unconscious, is shallow respirations. The first thing you do is to attend to their airway, which is the A in the ABCDs. So you make sure you maintain your airway and you restrict cervical spine motion. And B is breathing and ventilation. The C is the for circulation and hemorrhagic control. D is disability. This is when you check your LOC exposure. So when you then expose your patient and you control the environment. So please note that there are two things that usually go in hand. Is A, there is airway and C spine. B is breathing and ventilation. C, circulation and hemorrhagic control. D is just the LOC and exposure is E. All right, so further elaborating A, please note that you can quickly assess your patient within 10 seconds. How do you do this? You get to your patient, you identify yourself, you introduce yourself. Hi, my name is Dr. Chihobo. I'm going to be your patient today. What's your name? And if the patient can speak and even tell you what happened, it means that there isn't much compromise to the airway, because the one they can speak means they can breathe. If they can speak, it means they can also generate enough air to produce sound. So that means they are probably breathing well. C, if you're breathing profusely, your LOC might be low. But if they are speaking and can even narrate, they are probably conscious, and their LOC is 15. So you do a quick assessment by just asking them, what's your name, what happened? But then, if they are not responding, you then move on to the A that we're talking about. But still, you're still assessing your airway with C-spine motion restriction. So how do you assess your A? You check if your airway is patent, you inspect for foreign bodies in the mouth, you identify if there are any facial or mandibular or tracheal laryngeal fractures or any other injuries that can result in airway obstruction. And if there's any foreign bodies, you scoop the foreign bodies out, you suction the patient to clear any accumulated blood or secretions that may cause airway obstruction. And if the patient is unconscious and there's no gag reflex, an oropharyngeal airway might be helpful temporarily. Because if the patient is unconscious and lying on their back, the tongue can close the airway. So if you put an oral airway, it lifts the tongue and then it opens the airway. So there are maneuvers that you do to open the airway as well. There is what is called a jaw thrust. So in trauma, a jaw thrust is usually preferred compared to a head to chin lift. Because remember, you are already suspecting there's a C-spine injury. So you need to do your jaw thrust. If you do the head to chin lift, you might worsen the injuries. So if your LOC is less than 8, you then consider to put a definitive airway. Some people might ask, what's a definitive airway? So a definitive airway is two components. It's an airway that's below the focal cords and it's curved. So for example, intubating with an endotracheal tube or putting a surgical airway. All right. So whilst assessing the airway, like I said, you should take great care of excessive movement of the C-spine. So there are two ways you can do it. So what you see on the is what is called an inline C-spine immobilization. So that patient restricts C-spine motion. Or you can use a heart neck collar, which I haven't seen in our ER or our resuscitation unit. We had one patient whom we suspected to have C-spine injury. We had to hold the neck until someone else brought a heart neck collar. So yeah, you saw that this is the inline C-spine immobilization. And once you have assessed your airway, you then move on to B, which is your breathing and ventilation. But please note that, for example, you've seen that there's a foreign body or you've suctioned. Once you've managed, make sure you reassess, you go back. So once you've done everything, you've immobilized your C-spine, you still check if your airway is patterned before moving on to B. All right, so that's fine. You then move on to B, which is breathing and ventilation. So how do you assess your breathing and ventilation? You do what is called an EPA. You inspect, you palpate, you percuss, and then you auscultate. All right. So adequate gas exchange is required to maximize oxygenation and carbon dioxide elimination. So ventilation, in its essence, it requires that the patient's lungs are functioning, the chest wall is not injured, the diaphragm is also functioning well, and you should quickly and rapidly examine these components. So the inspection, palpation, percussion, and auscultation should be done rapidly. And if there are any injuries that impair ventilation in the short term, should be managed. For example, your tension pneumothorax, your massive pneumothorax, your open pneumothorax. So your tension or your massive pneumothorax, you insert a chest drain. And after you insert the chest drain, you go back to air again. First, if your air is still patent, and then you move on. If it's an open pneumothorax, you put an occlusive dressing. If it's tracheobronchial injury or tracheolaryngeal injury, you might consider a surgical airway. All right. So every injured patient should always receive oxygen. This is something that's usually forgotten. So if you get a trauma patient, once you've done your airway or you make sure it's patent, you put your patient on oxygen, high flow oxygen, with an non-rebreather face mask to make sure that there's optimal oxygenation. So it's high flow oxygen, the non-rebreather face mask, and then other things like your simple pneumothorax, your fractured ribs, your flared chest might distract you. And these are things that you might then manage after you've done your secondary survey, after you've dealt with the life-threatening conditions that I had alluded to earlier. All right. So after you've managed to B, you move on to C. But before moving on to C, you go back to A, assess your B, you move on to C. And then once so in C, sometimes you might see a patient who is in shock. So you also need to exclude the tension pneumothorax, which you have done. If you have done your things properly on B, you've excluded tension pneumothorax. So now the cause of shock will be definitely hypotension due to blood loss. Most likely, in most cases, after you've ruled out tension pneumothorax, the major cause of hypotension following injury is usually due to blood loss until proven otherwise. So the elements of the clinical observation that give the important information within seconds are your LOC. I think I mentioned this earlier, that when you quickly asking the patient the name and what had happened, if the LOC is 15 on 15 and skin perfusion is okay and the pulse is bounding pulse is regular, most likely circulation hasn't been affected much. If there's bleeding, which you can then classify as either external or internal bleeding, you can further expurgating on the terms. External bleeding, you attend to it during the primary surgery. First thing that you do when you see someone is bleeding, you apply pressure. Put a pressure bandage, and if it's extreme exsanguination from extremities, and you've applied direct pressure and it has failed, you then consider putting a tourniquet, knowing that the tourniquet might lead to ischemia and amputation of that limb. So internal bleeding, the internal bleeding is what usually classified under the formal. So when you see a patient who's hypotensive and probably due to with hemorrhagic shock, there's things that you consider. We call it the floor and formal, 4 Fs. So the floor and formal. So the patient had either bled externally, which is the floor, formal areas, they bled into the chest, bled into the abdomen or the pelvis, and then they bled into the long ones as well. These are things that usually cause massive hemorrhagic shock. For example, you can lose up to 2 liters of blood in each limb. So if you have a bilateral femur fracture, you can lose 4 liters, which is 4/5 of your cardiac output. And if you have a fractured pelvis, you can lose your whole cardiac output into the pelvis. The patient can die rapidly. Another example that other people tend to ignore, for example, you've seen trauma in a patient who's pregnant and is bleeding PV. Note that at term, the uterus receives about 700 ml of blood per minute. So if you then see that patient who's bleeding at approximately losing 700 ml of blood per minute, it means within 7 seconds the patient will have lost their cardiac output and died. And what then happens is you see that patient was bleeding profusely. Someone has already inserted a blue cannula, which is a 22G. So in trauma, we usually don't want all the other colors. We want what is called a large bore cannula, which is either your green or your orange. So I think you can see the diameters and the length, but what I'm more interested in is the flow rate. For example, you put in 2 large gray cannulas, and you are running 2 liters of normal saline. If the patient is receiving 180 ml per minute, it means that within the 7 minutes that the patient could have probably lost their whole cardiac output, they've received about 2.4 liters of blood, which is okay because you're leaving a patient in at least grade 2 shock, and you can still manage the patient. But however, so going back to this, how do you then assess? You do a trauma series, which are x-rays, your chest x-ray, your pelvic x-rays, you do your long bones, your C-spine. What you can quickly do is what is called a FAST. So this is a focused assessment with sonography of trauma. It's an ultrasound. It's very quick. You can do a FAST. You look at the windows. You look at the pericardium. There's nothing. Behind the spleen, Morris pouch. It's a quick assessment that you can do. And then the other one is a DPL. DPL, diagnostic peritoneal lavage, is more complicated compared to the eFAST. So at most facilities, it has been replaced by the eFAST ultrasound. And like I had said, you put your 2 large bore cannulas, you collect your bloods for FBC, ABGs, and if you have childbearing age, you also consider pregnancy test. You cross-match, do blood type and cross-match, and then you resuscitate. So in terms of resuscitation, there's been concerns with aggressive resuscitation. So if you resuscitate your patient aggressively, you might then end up with problems because the patient might then develop disseminated intravascular coagulation, and now you have more problem than the first you started with. So, like I said, the type of shock is usually hypovolemic due to hemorrhage. You start your crystalloids, and we had said you've already warmed your fluids, so they are within the temperature of 37 to 40. You also don't want your trauma patient to develop hypothermia. You run your 1 liter fast to achieve an appropriate response. If there is no response, you then consider transfusion. You've already sent blood for blood type and cross-match. Like I said, aggressive resuscitation before control of the bleeding has been demonstrated to increase the mortality and morbidity. So the European and American military studies have demonstrated that there is improved survival if you give tranexamic acid within the first 3 hours of injury. So you've resuscitated your patient, you give your boluses, you give your tranexamic acid. Because why? Because it has been shown to work from the military studies from the European and the Americans. And then, so there's also what is called grading of shock. Shock is graded 1 to 4. So if it's grade 1 to 2, it should definitely respond to the crystal wave that you've given. But if it's grade 3 and 4, you definitely need to consider blood transfusion. So there are certain parameters that you use to grade shock, but we'll not dwell on that. So moving on, you move on to your D. Like I said earlier, it's a rapid neurologic evaluation, which you do using your Glasgow Coma scale. You assess your LOC, and this is something that you then continue to use when you are evaluating a patient as well. You rule out hypoglycemia, you do your rapid glucometer, you also know that there are other things that can affect your level of consciousness, which include the hypoglycemia that we alluded to, alcohol, narcotics, and other drugs. But in some instances, this can refer to two things. There's been patients who are ignored because they smelled of alcohol, but they had severe trauma and their level of consciousness was very depressed. And there are certain situations where patients have been intubated when they were just under the influence of alcohol, only to then find them in the next day removing the ETT. And they are now so. But in whatever circumstance, even if you smell alcohol or not, you still do the same things that you do with the patient who's not intoxicated. So until proven otherwise, always assume that changes are due to the CNS injury, not to anything that has been taken by the patient. All right. So the other thing that you need to then consider is to make sure that you are preventing a secondary brain injury, which can be prevented by maintaining adequate oxygenation and perfusion in the initial assessment. So patients with evidence of brain injury should be treated at a facility where there is personnel and resources that anticipate and can manage these patients. You can either consider transferring or consulting early when you've seen a patient with traumatic brain injury. So when you're exposing, we are moving on to E. But please remember, before you move on to E, you're going back, you're doing a quick assessment of your NDC again, then you move on to E. You now expose your patient. How do you usually expose a patient? What we usually do when we get to a patient who's been involved, maybe in an accident, or there's a big scissors that we use to cut down the clothes. We just cut them from even the shoes. That scissors can even cut shoes. You expose your patient adequately. Because trying to remove the clothes might then injure the patient again. So you cut the patient's clothes. You assess the patient. How do you assess? It's usually what you do is you do a lock roll. You lock roll the patient, then you check the back because you have assessed the front part, assuming you've done everything properly. You lock roll the patient, and when you lock roll the patient, this is the time when you then get to attach any monitors that you need to attach to put your cassettes for the X-rays, and then you roll back the patient, and then you bring an AP, a mobile AP, you do your X-rays. But after you've assessed, you make sure that you warm the patient again. Remember what we said, we want to prevent hypothermia. You either use warm blankets or you continue with your warmed IVs. All right. So there's certain things that we call adjuncts to primary survey. So these are basically things that we'll be using during the primary survey. And some of them we have them, and some of them we don't. So these are your pulse oximetry, SpO2, your ECG. You put your ECG leads on. There is a capnography, which also monitors the carbon dioxide. And if your patient is intubated, you're monitoring your ventilator rate, and you've sent blood for APGs already, arterial blood gases. So arterial blood gases are important in trauma because they can also be used to classify the shock. If you look at the blood lactate, you can see if your resuscitation is adequate or still inadequate. In addition, the other basic things that you put, you insert a catheter, you monitor your urine output, you assess for hematuria, you put an NGT to decompress any distension and to assess if there is any evidence of blood. In some of the things that we've mentioned, your fast, your X-ray or your TPL. So there's another slide just showing the adjuncts to primary survey. All right. So after you've done your primary survey, you do what is called a secondary survey. So secondary survey is when you take what's called an ample history. You check if the patient is an allergist, are they on any medications, do they have any past illnesses, or are they pregnant, when they take their last meal, etc., etc. And then you do a quick head to toe examination. So this is now a thorough examination, but you do head to toe. So after that, you initially assess your patient. If I was to go on explaining A, B, C, D, it would take us the 3 days, which is why the course is 3 days. But anyway, thank you very much for your time. I think this is the end.